All right, so we need to talk about our leaders when it comes to the development of theories and how they've actually been applied into practice, and those who have been relevant in the practice of and development of mental health treatment. Okay, so um, we need to understand the difference between psychology and psychiatry. Anybody know the difference between psychology and psychiatry? Sam.
I don't, I'm sorry.
Okay, anybody know the difference?
Psychology is more of working with the mind, and psychiatry is more of a doctor's specialty where they have to prescribe medication, and it's more leaning towards medication, where psychology is more towards therapy.
Fabulous. Very good. Excellent. Thank you very much. Great description. Absolutely. Okay. So the big difference is, just like Ms. Damon was telling us, is that psychology is going to focus more on the therapeutic aspect of treatment. Therapy, whether it be individual, group, cognitive, behavioral, interpersonal, whereas psychiatry is going to also implement the treatment modality associated with pharmacology, specifically psychopharmacology. So the goal is actually for psychiatric nurse practitioners to not only know the medication aspects of treatment for a patient, but also know how to do some of the therapeutic aspects, to develop our communication skills, to develop procedures and opportunities to engage with patients. So also being able to use the therapeutic aspect. In a perfect world, I would be able to do that as well. I would love to be able to sit and do therapy with my patients. Unfortunately, there's not a lot of prescribers that are specific to psychopharmacology or to mental health medications. So unfortunately, that relegates me to doing a lot of medication management. So although I would love to be able to engage patients in some of the more therapeutic aspects of treatment, I am, because there's such a shortage of medication prescribers specifically for psych, I am really relegated to doing medication management. So for me as a nurse, it's really, really hard because I like talking to patients. I like getting to know them. I like knowing what's going on and seeing if we can work through things together. Unfortunately, 30 minutes with a patient does not allow me to have that much time with them. 30 minutes allows me to go through a medication regimen, go through their plan of care regarding psychopharmacology, check how their signs and symptoms of the disease processes are occurring, are being negated, or being evaluated and effectively treated. So it limits the amount of time that I'm able to spend with patients. So psychiatrists, psych nurse practitioners, psychiatric nurse practitioners are very specific to having that modality where they can prescribe, just like Jackie was saying, versus psychology has more to do with the therapeutic aspects. In the goal, and understand that this is really, really important, guys, the goal is to do a dual modality treatment for all patients. Okay, so here's the thing. I told you guys that chances of successfully treating a patient for mental illness is very challenging because there's no cure for mental illness. There are only steps to making it better, to making their situations better. And what we have found is if you can actually pair medication management with therapeutic management and combine both modalities, the chances of successfully treating a patient with mental illness is 85%. Important. That's important. Okay. So treating a patient with a dual modality treatment regimen, utilizing both medication management and therapeutic management, can result in a patient being treated 85% effectively. The problem is getting the buy-in from the patient because the medications are not always fun. The having to dig into your interpersonal feelings and share your thoughts and share some pretty dark places that you may go are not easy things for people to express or get into an engagement of a therapeutic relationship. So the challenge is getting people to buy into it. If we can, again, 85% success rate of treating patients with mental illness. Now, if we use a single modality, let's say the patient says, you know, I'll do therapy, but I want nothing to do with medications. That's okay. At least they're trying. If a patient says, I just want medications, but I don't want therapy, this greatly reduces your chances of successfully treating the patient. It actually takes it down to about 40 to 50% if you use a single modality, meaning if the patient doesn't combine therapy with medication or medication with therapy. And here's the problem, guys. Patients walk in the door and they want a magic pill. They want you to give them something that will make their life better, that will take away their depression, that will take away their anxiety, that will take away their stress. And there is no magic pill. There isn't. I wish there was. If there was a magic pill to take all those things away, I'd be the first in line to grab that pill. But there isn't. The only thing that we do is we can have tools to help the patient, but not eradicate it. The only way to successfully treat is if we can do both pieces and if we can get the patient to buy into that plan of care. Again, though, that's the challenge, is can we get the patient to stick with it? And here's the other challenge. Yes, awesome. We get the patient to stick with it. They go to therapy, they're on medication, we can get them regimented. But 6 months down the line, they're doing really good and they go, I don't need medication anymore. I don't need to go to a therapist anymore. And what happens? They fall right back into the same issues that they had previous. Because remember, there is no cure for mental illness. There's only steps to making the situation better. And so oftentimes when patients engage in medication and therapy, oftentimes those same patients are going to come back to you within a year to 3 years because they'll go off their medication, they'll stop seeing a therapist, and then they'll start to have those same problems occur again. That's not always. Some patients can be really successful. I've had a lot of patients that say, I don't want to be on medications anymore, but, I'm using mindfulness now. I use yoga, I exercise, I eat better. I'm in supportive relationships. I'm out of abusive relationships. So they can change their environment potentially to make their life better. But ultimately, if it's a chemical issue associated with the dysregulation of neurotransmitters, we're going to have some deeper issues to deal with. Okay. But the big piece here, guys, is the combination of a dual modality of therapy and medication management. Okay. Questions about that? Okay. Let's go back to it. All right. So we know that there are certain theories that have been developed that assist in treating patients with psychological issues. Psychological, truly looking at the psychosocial perspectives that patients are experiencing. And so we're going to go through quickly a couple of the theories and therapies that are relevant to nursing and that we're going to see particularly in mental health care. All right, there we go, psychoanalysis. So here he is. Sorry guys, I had to bring him up. Here's good old Freud. I don't know about this guy. I think he did enough heroin to put down a small horse, but that's my own personal He was a little bit interesting there. I don't want to discredit Freud because he did some really great things, but he was also he was a very misogynistic person, and he did a lot of his testing on women, particularly females that had mental health disorders. So a lot of his research was done on females, and some of it was unethical, to be quite honest. And he really truly felt that at the root of everything was the issue that were associated with women having mental illness, had to do with truly them being females. So anybody know where the word hysterectomy comes from? Apparently, what the word hysterectomy came from the concept that women who had uteruses would become hysterical during their period, or they'd become hysterical before their period. And so in order to curtail their hysteria, we were going to take out their uterus. Hence the word hysterectomy, take away the hysteria. So our fine friend there, Mr. Freud, was one of those people behind it that said, oh yeah, I think if we take women's uteruses out, they might be less excitable, they might get less depressed, they might be less stressed or anxious. And so he would come up with and solidify concepts like hysterectomies. One of the other things he liked doing was taking women's teeth out. Apparently, if you took women's teeth out, infection would brew in women's teeth. So in order to curtail them from having stressful events or being anxious, that he would take their teeth out. So he was very much a misogynist when it came to treatment of women. So apparently taking your teeth out and your uterus would make you non-criminally or mentally ill. We obviously know that that is not true. But unfortunately, you will see in mental health as we progress through this, and they come up with concepts like refrigerator mom, which meant that mom was cold to a child, and hence, if a mom was cold to a child, you now had a child with autism. Okay, so all of these things were I'm not picking on you guys, but I'm telling you that there really have been a lot of really maltreatment there has been a lot of maltreatment when it comes to mental health, particularly with females. And at the heart of it were males doing the research. So it's been a challenge. So as much as I appreciate what Freud has done, because he has come up with psychoanalysis, that whole concept of putting the person on the couch and listening to them and allowing them to share their feelings and express how they feel, that's really important. We still use psychoanalysis to this day. However, there were some judgment calls that Freud made that were very poor. And so I'm not 100% on board with Freud, but I do think he had some great contributions. All right, questions thus far? Don't worry, hopefully we are not still taking people's uteruses out because they're hysterical anymore. We come up with that one. All right, so we keep going here. All right, so Freud said that there are 3 levels of awareness: conscious, preconscious, and unconscious, okay? The conscious was what we did on purpose. We knew what we were doing. The preconscious was something that we were potentially thinking of doing, and then unconscious were things that happened when we weren't awake or alert, okay? Again, this is review, so I'm going to go through a quick guide. Guys, id, ego, and superego. Id, ego, and superego. This is the id was the pleasure principle. That was the me. It was about me. It was about what made me happy. The ego was the problem solver. It was the reality tester. And then the superego was your ethical or moral compass that really brought you into identifying what types of things were bothering you, or what you had to supersede or had to rise above from a moral perspective. He looked at defense mechanisms and anxiety, and he felt that these operated on an unconscious level. Okay, so we talked about a little bit last week about distress and eustress. Remember, eustress is good stress. We need it. We need it to protect ourselves. We need it to know that we can't cross the street when there's lots of cars running, because our defense mechanism says that this is not a good thing to do. That stress is important because it keeps us safe. But we also need to be able to understand that we have to be able to deny, falsify, or distort reality to make it less threatening sometimes. Meaning that sometimes the things that appear to us that are frightening or scary, we have to distort them so that we can actually live with what's happening. Okay, yes, all these cars are on the street and it's really scary and I don't want to cross the street. But if I picture that all these cars are going really, really slow and they're all VW bugs and they're all pink with flowers on them, oh, I can cross the street and not be so nervous this time. So what I've done is I've distorted reality so that I can deal with how scary something truly is. Kind of make sense, guys? He said experiences during the early stages of life determine the individual's lifetime adjustment patterns and personality traits. So I got to give this to Freud. This is true. Okay, we know that the first 5 years of life, 85% of our cognitive development is established by the time we are 5 years old. Anybody heard of that program called First Five? Okay,
Yeah.
the reason that they say first 5 is because so much of our cognitive development is already established by the time we're 5 years old. So basically, yes, Freud had something going there because of the fact that so many of the experiences that we have as children would help to define us as adults. So if we are read to, or sang to, are drawn with, or engaged in music, or whatever the case may be in those first 5 years of life, it's definitely going to help us as we move forward. If we're in a nurturing environment, an environment that we see love and support, it's going to affect us as we get older. And so the whole concept of that nurture nature concept really did have a lot of its emphasis designed in some of the things Freud thought of. Again, I got to take him with a grain of salt. Okay, all right. Some of the things as Freud related to nursing, some of the things that were important. We do know that Freud had concepts associated with personality formation. The big 2 things, okay, so highlight this. These are 2 things that you really have to know, really important. Transference and countertransference. I talked to you guys about this before. This is going to be on your exam. I'm just telling you right now. It's an important concept to remember. Okay, so countertransference and transference. Let's talk about that. Transference is when the patient feels something about the provider or the caretaker. It means that they are exemplifying or they are portraying to you something they see about you that they identify with. So let's say, Deanna, let's say my best friend is a petite Asian woman, right? And I see you, and in you, I see my friend. So I'm going to be a little bit nicer to you, Deanna, because you remind me of my friend. I'm going to be kinder to you. Maybe I'll talk to you a little bit sweeter. Maybe I'll be nicer to you. Okay, so I, as your patient, am going to be nice to you because I, as the patient, see that in you. Okay, does that make sense? So I, as the patient, am transferring those feelings that I have of my best friend onto you. I'm going to be nice to you as my nurse today because you remind me of my friend. Now, you, in retrospect, I remind you of someone you don't like. Maybe I'm a girl I look like a girl you went to school with that you don't like. You're my nurse, and something about me is not something you're comfortable with. So you have transferred, as the nurse, your feelings, your negative feelings onto me. That is countertransference. It doesn't need to be negative or positive. All it needs to be is that feelings have been identified for the person, the opposite person that you can actually empathize with or you can identify. So transference is when the patient experiences in you something they can identify with, and it can be negative or positive. Most times with transference, you'll see it when a patient reacts to you. So if the patient goes, God, ooh, I hate you. You look just like my sister. My sister was always a B to me and I can't stand that woman. And ugh, I hope you're not like my sister today. Okay, that's the patient telling you from the get-go, this is probably not going to go too good because you remind me of my sister. Now, in hindsight, now you as the nurse are taking care of a patient and you're like, that patient just rubs me the wrong way. It reminds me of somebody I went to college with and I couldn't stand that person and they just grated on me the whole day. So you as the nurse are having trouble with the patient. That is countertransference, okay? You need to know the difference between the two and you need to know the definition of the two because of the fact that it happens so much in mental health. Because we do identify, we do see people, we do have people that remind us of other people, and it can instill feelings in both the patient and the nurse, okay? Transference and countertransference. Please know those two terms, it's really important. All right, so let's give an example. Okay, Deanna, the patient is admitted to your unit who has an uncanny resemblance to your older sister. As a child, your older sister bossed you around and criticized you constantly. You realize that you are responding negatively to this patient. What is going on? Is this transference or countertransference, Deanna?
Countertransference.
Absolutely, because you as the nurse are identifying that there are experiences and feelings that you have toward the patient. Very good. Okay, so what should the nurse do? What do we think the nurse should do? Hunter, do you think I should give this patient up or should I try and just work through it and take care of the patient? What do you think?
I think you should still try, but if it starts going a little wrong, then maybe talk to your charge.
Yeah, I would agree. Do the best that you can. Unfortunately, a lot of times, especially in mental health, we can't really trade patients around. You want to try and keep the patient because if you let the patient go, the patient may take it very personally, like, what's up? I thought we had a good relationship. What happened there? So do your best to try and stay with the patient. But if you really feel that it's negatively impacting your patient care, then I would definitely ask to see if you could have your patient switch. Very good, Hunter. All right. Erickson's ego theory. All right. Here, let me just tell you this. When I took my boards, Erickson's ego theory, I had 3 questions on my NCLEX. Never forget it. On my advanced practice boards, I had 7 questions on Erickson's ego theory. You will get questions on Erickson's stages of development. I promise you that. It is they are fundamental concepts associated with growth and development. So you have to know these. All I can tell you is memorize them. They're important. I promise you, as I said, I saw them on both sets of boards. I was really surprised when I took my NP boards. I was like, hey, here's Erickson again. And sure enough, he showed up again. So you need to know trust versus mistrust. You need to know autonomy versus shame and doubt, initiative versus guilt, industry versus inferiority, identify versus role confusion, intimacy versus isolation, generativity versus self-absorption, and integrity versus despair. Learn them. It's important. You got to memorize them. They are on your exam. Okay? They're on your exam because of the fact they are so important. They're fundamental. It's like having to know your nursing diagnoses. This is just one of those things you have to know. Okay, so stages of development, very important. Okay. His theory and nursing model is the developmental model that's important to part of nursing assessment. We use it in assessment all the time. We know that we're going to use it accordingly on how we actually develop a plan of care for a patient. It's going to help us to determine what types of interventions are most likely to be effective based on the child's age or the person's age. Sullivan had the interpersonal theory. Her purpose of this was that all behavior needs to meet through interpersonal interactions and reduce or avoid anxiety. Sullivan was important. We do use her in mental health treatment, but hers really looked at anxiety, security, and safety. So the reason why Sullivan's important is because safety was a cardinal hallmark of her theory, because of the fact that she felt that if the patient felt safe and secure, their anxiety would be lessened. And that's pretty true. Paplow, there she is. Okay, Hildegard Paplow is the mother of psych nursing. Okay, just like, who did Paplow in theory? One of you guys had Paplow in theory. Who was that? Can't remember who, which one. Somebody had Paplow in theory, but basically Hildegard Paplow was the mother of psychiatric nursing, just like Florence Nightingale is the mother of nursing. She's the mother of psychiatric nursing. She really looked at Sullivan, the theorist Sullivan's work, and created a concept associated with the art of nursing that would provide care, compassion, and advocacy. And this was a big jump because people with mental illness didn't have a lot of advocates for them. They were put into sanitariums, the door was locked, they were put in rubber rooms, or they were chemically induced to be in, a semi-type of coma, or a level of consciousness would be decreased, or you'd put patients in straitjackets, or you'd put them in restraints, and nobody really advocated for them until the 60s started to hit. But really, Paplow really said we have to look at these people as individuals with illness, not just throw them away once we identified that there's been an issue associated with mental health. She also looked at the LSD level of anxiety. She developed interventions to lower anxiety, and her goal was to improve patients' ability to think and function. Some of your behavior theories, here's some of them. We've got Pavlov, Watson, Skinner. Again, we guys saw a lot of these guys in theory. A lot of these were mental health theorists, and we utilize them in theory as well. But the nice thing about it is that a lot of these, like Pavlov, Watson, Skinner, all of them translate very, very well into nursing theory because of the fact that they're so integrated into caring for the patient, reducing the level of anxiety, and allowing the patient to feel safe and secure in their environment. These are some of the behavioral therapies that can be used, like modeling. Modeling we use a lot with kids, where we'll have a child that, let's say, is really disruptive in class, and we have them hang around with a kid who's not. And so they can model behaviors based on a child that has more appropriate behaviors in school. Operant conditioning, systematic desensitization, those types of things are like when we slowly introduce things that might be stressors to a patient. So maybe the patient has trouble going outside, maybe have something like agoraphobia. So we say, okay, in the very beginning, we're gonna just have you walk out to the porch. And on the porch, you'll sit there for 5 minutes for the next 3 days. And then after 3 days, we'll take it to 10 minutes. And then after 10 minutes, we'll take it to 15. And then maybe we'll get off the porch and we'll walk down the street, and we'll do that for 5 minutes. So it's systematically, you're desensitizing them to whatever their stressor is. Aversion therapy is really interesting too. It's basically like putting a person in front of something that really scares them. So maybe they really hate rattlesnakes or snakes or something, right? And so you take them to the zoo and you expose them to that snake. And even though it may make them really scared or really nervous, you expose them to it so that they can become desensitized to that particular stressor. And then biofeedback uses a lot of interpersonal types of communication and therapy, where we allow the patient to use like biological means, and we do biofeedback. Like biofeedback is used like a lot with like yoga and with mindfulness, and really, tapping into a person's interpersonal relationships and feelings and allowing them to express that. Cognitive theories are really interesting. It really looks at the dynamic interplay between individuals and the environment. So we use a lot of environmental types of stressors and environmental types of reasoning so that the patient can identify that their thoughts come before feelings and actions. So they can actually identify, what are you thinking right now? And as a result of what you're thinking, how are you reacting to it? So it's kind of like deep, but we use like cognitive behavioral therapy for people who have like things like PTSD. So maybe they've been in combat, or maybe they've had like a really, really scary experience. And so what we want them to do is identify that there's a stressor. And then before they react to it and start screaming or hollering or, you know, crawling into a ball in the corner, they come up with a plan. Like, if this happens, I'm going to do this so that I can evade or I can stop my response from being this. So it's like steps, almost like a guidebook as to what you do when something occurs. And it works really well for people with like PTSD and certain types of trauma or stressors. The father of cognitive theory is Dr. Aaron Beck. And every year, it's really cool, he actually puts out like a scholarship for 30 nurses and nurse practitioners to come to his ranch in Colorado and teach them how to do cognitive theory and cognitive behavioral therapy. It's really, really neat. And it's found some great successes, particularly with patients who've had major trauma in their life. Because then they can identify, if this is going to happen, I can react this way so that ultimately I don't end up having a panic attack, or I don't end up having to run back home, or I don't end up having to pull over the side of the road because I can't breathe anymore. So it's really kind of interesting. He's really come up with some really innovative approaches. One of the types of therapy that falls under cognitive, like I said, is CBT, which is Dr. Beck. And he tests distorted beliefs and changes the way of thinking by reducing symptoms. And then what we call REM, which is rational emotive behavioral therapy. It aims to eradicate irrational beliefs and recognize thoughts that are not accurate. All right, humanistic theories, Maslow, there's another one. Erikson, Maslow, know them. That's it. You got to know Maslow too. Maslow's hierarchy of needs. We know that in order for us to do anything, we have to be able to eat, drink, eliminate, sleep, all the things that allow us to function. There's this, you know, we can talk about the thinking and rationale, and we can do our best to take care of a patient. But if the patient hasn't ate or drank or provided himself with the necessary means to live and function, then it may be a moot point. We can treat a patient from a psychosocial perspective, but they also have to be fed, and they also have to drink water. And they also, if the person has to urinate or defecate, you're not going to get much attention from them if they have to go to the bathroom. So being able to address what their hierarchy of needs are as far as living is going to be important. So know Maslow, it's really important. They emphasized the human potential and the patient's strength, and prioritized nursing actions on the nurse-patient relationship. These are some biological theories, neurological, chemical, biological, and genetic. This all incorporates that whole concept of nurture nature and how the brain interacts to create emotions, memories, and perceptual experiences. Okay, guys. Oh, this one, milieu therapy. You guys got to know this. Okay, what is milieu therapy? Milieu therapy is the integration of the environment. It means that the environment the patient is in provides a safe, secure, emotionally supportive setting and structure that promotes healing. Okay, so you're at the hospital and you are taking care of patients that are, you know, obviously have some type of mental illness. It's much easier to take care of a patient that's in a secured environment versus if you had a patient, God forbid, let's say you were in a third world country or you were in a war-torn country and you can hear gunfire outside and there's Molotov cocktails being thrown and there's people screaming outside because they're, you know, protesting, whatever the case may be. That is not a safe milieu environment. That is not a milieu environment that is going to promote health, safety, wellness, emotionally supportive area. So the environment also has to be really, really, it has to be utilized from the perspective that it creates the best place for the patient to get their care. So milieu therapy has to do with the incorporation of the environment being supportive for the patient's emotional, and spiritual well-being. Okay, milieu, safety. Don't forget that, important. Okay, yes, ma'am.
Would that be kind of like when a patient is going to rehab or something like a sober living house? Would that be like okay?
Absolutely. Perfect example. Absolutely. So milieu therapy in that environment is providing them with a safe place in order to be rehabilitated in their particular substance abuse disorder or alcohol abuse disorder or whatever substance that they are trying to potentially come off of. That's a perfect example. Milieu therapy in a rehab facility would be exactly what you would consider. Now, let's say you had a patient who said, I'm going to go cold turkey. I'm going to do it at a buddy's house and we're going to do it in his back garage. I'm going to detox in his back garage and I have a bucket and, you know, he's got 5 kids in the house and hopefully they won't come running in and out. That is not a supportive milieu environment. It doesn't preclude itself to being a safe, supportive, emotionally attached environment that can perpetuate the wellness that the patient needs. So absolutely, what you described was great versus something that would not potentially be the best environment for the patient. All right, so let's talk about the biological basis and understanding psych disorders and treatments. All right, so we know that this is again review, just functions of the brain. We know the brain is going to provide maintenance for homeostasis. It regulates our ANS, our autonomic nervous system, and our hormones. It also controls biological drives and behaviors, and it's responsible for a cycle of sleep and wakefulness. It also assists with circadian rhythms, which again are part of sleep-wake issues or sleep-wake functioning, conscious mental activity, our memory, and our social skills. Cellular composition of the brain are going to be your neurons, and we'll talk about neurotransmitters this evening. The responses to stimuli, we know that they respond to stimuli, they also conduct electrical impulses, and the chemicals that are released specifically from neuronal action is going to be your neurotransmitters. Cellular composition of the brain, when the presynaptic occurrence happens in the neuron, we know that it occurs, it ends synapsing into the postsynaptic neuron. So basically electrical charge goes through the neuron, it synapses through and then ends up in the postsynaptic neuron. Transmitter destruction occurs through enzymatic destruction as well as reuptake. Neuronal action can release more than one chemical at the same time. So we know that particularly if we look at things like anxiety and depression, we know that the major neurotransmitters associated with those two disorders are going to be serotonin and norepinephrine. So you can release more than one chemical at the same time. In fact, most actions that our brain does involves more than one neuronal action. Neuropeptides are the long-term changes in the cells. Neurotrophic factors have to do with proteins and gases, which I think is really interesting because if you look at things like organic brain syndrome, like Alzheimer's disorder, if you look at a patient post-mortem after they have been diagnosed with Alzheimer's disorder and they do an actual autopsy on the patient, what you'll find in the actual crevices of the brain when they do the autopsy are actual protein buildup. In fact, the proteins that we identify in the brain post-mortem from organic brain syndromes have an almost 80% relevance to algae. So the proteins that you see in algae, like that grow on the rock, are very similar to the chemical compounds that we find in the brain, which I think is really interesting. So it's almost identical in its cellular makeup, and all the proteins that are involved in algae are very similar in the brain when we have issues like organic brain syndromes. Just kind of throwing that one in there. And then also has to do with gases and effect of steroids and hormones. We know that the brainstem, the cerebellum, and the cerebrum organize our brain, and the functions of the brainstem are specifically to regulate internal organs with vital functions. Our hypothalamus, really important little gland in there. It provides the basic drives and links between thought and emotion and functions of the internal organs. We notice that if there is frontal lobe damage in the brain and the hypothalamus is involved, it can have major changes in the patient's mood, in the patient's personality. We see major personality changes when there's been trauma to specifically the frontal lobe of the brain. The brainstem is an area that's that uses processing sensory for information. So it's the processing center for it. And the cerebellum helps to regulate skeletal muscle. So this is going to help with equilibrium, coordination, and contraction. Interesting thing, there are certain types of neurocognitive disorders like Parkinson's disease and ALS that with long-term use of certain types of medications, particularly psychotropic medications that are antipsychotics, will have much of the presentation that you would see with a patient that had a movement and coordination disability like Parkinson's or ALS. So if you have a patient that has been on risperidone and been on olanzapine, which is a mood stabilizer and antipsychotic, and they've been on them since they were 23 years old and they're now in their 60s, so they've been on these medications for 40 years. We see that coordination and movement has many of the same symptomologies associated with Parkinson's disease. They don't have Parkinson's disease, but they have a lot of the same presentation because of the fact that the medications have had such a huge bearing on the cerebellum. The functions of the cerebrum are mental activities, conscious sense of being, emotional status, memory, control of skeletal muscles and movements, language and communication. So we know the brain is pretty much responsible for everything, or at least regulation of our organ systems. How we visualize the brain are 3 different types of imaging. It basically goes from weakest to strongest. We know that CTs and MRIs are potentially used to look at structures of the brain, but don't necessarily look at tissue. They just look at the structures themselves. The MRI is obviously going to be a lot more resonant regarding visualization, but the best types would be potentially a PET or a SPECT. Now, we don't use PET and SPECT for diagnostic purposes all the time with certain brain disorders. But if a patient has had long-standing types of disability associated with neurocognitive functioning, they may use them. They're very expensive. You have to have a lot of substantiation as to when to use them. CTs, not as much, MRIs, not as much, but for a PET or SPECT, you better have your ducks in a row as to why a patient would need to have those types of imaging done because they're very expensive tests. We know that these right here, see these guys, norepinephrine, serotonin, dopamine, glutamate, and GABA. You need to know these. These are all your really important neurotransmitters. The reason you need to know them is because they all have something to do with the medications that we treat patients with mental illness for. Serotonin, there's your big one. That's an antidepressant. It's the medication that is specifically involved in treating patients with serotonin dysregulation. Norepinephrine is going to be responsible for things like anxiety and stress. It's your fight or flight response. It's your run to it or run away from it. So you're going to see things like selective norepinephrine reuptake inhibitors, certain types of medications that are anxiolytic in nature will be involved with both norepinephrine and serotonin. Medications that are specifically used for things like dopamine are going to be things like dopamine is responsible for issues associated with disorders like alcohol abuse disorder, those who have issues with substance abuse like heroin addiction or any type of illicit substance will have a direct effect on dopamine. Glutamate and GABA are going to be your minor neurotransmitters. So your major neurotransmitters are norepinephrine, serotonin, and dopamine. Your minor neurotransmitters are glutamate and GABA. Okay, but the main norepinephrine, serotonin, dopamine, minor, glutamate, and GABA. Okay, let's talk about these. We're just going to kind of run through these guys because you guys are going to be doing these individually for us, or you're going to be doing your snapshot presentations with these. So your benzos, your diazepam, your clonazepam, the alprazolam, and the lorazepam, the PAM sisters, that's what we call them. All of your benzos have one thing in common. Leslie, what do you think, what is the main thing we need to know about benzos? What are the things that they have in common? What do you think, Les?
I'm not sure.
Okay, Abraham, take a wild guess. What do you think? What do they all have in common?
Antidepressants?
Their anxiolytics are actually anti-anxieties, but that's okay. But there's a reason that we have to be specifically cognizant about benzos.
Norepinephrine.
You're on the right track, but there was something that I wanted to, and good, you're on the right track. They cause drowsiness, you're coming along. Okay, here's the big thing. All of these, the PAM sisters, highly addictive. Highly addictive. These are all considered controlled substances. The PAM sisters are all highly addictive. Unfortunately, they're also way overutilized. It used to be 25 years ago, don't quote me on this, but it used to be the nurse's cocktail was a glass of wine and a Xanax at the end of a shift. So you would come home at the end of shift after a hard day and you pop a Xanax because of all the anxiety you went through and a glass of wine and you were out like a light. Not a good idea, okay? Don't combine a benzo with alcohol, not a good idea. It's also why we see more incidents of substance abuse disorder with the nursing profession. So we got to stay away from things like this. These are okay for short-term medications. We can use them for short-term periods for patients that have panic disorder or extreme stress, or really, they become so stressed that they can't breathe, or they have trouble like getting chest pain, that kind of thing. The number one reason that patients are seen in for mental health disorders is going to be stress, anxiety, and depression. We know that, right? And when patients have what we call somatic complaints, or physically their body is starting to feel the effects of a mental health disorder, patients will often be seen in the emergency room because they think they're having a heart attack. So a similarity between an anxiety attack and a cardiovascular accident or a MI are going to be the same types of symptoms. Difficulty breathing, shortness of breath, tightness in the chest, feeling like an elephant sitting on your chest, pallor, tachypnea, hyperventilation, all of those things, they sound kind of like an MI. But in this case, it's not cardiac in nature, it's actually mental health in nature. So a third of all patients that come in with chest pain is actually anxiety. So what do we treat it with? We treat it with a PAM sister. So most of the time we're going to give a patient a dose of Ativan while they're in the hospital. So we'll give them lorazepam. Lorazepam isn't injectable. So we will give them lorazepam. Sometimes we'll give them, we call it the cocktail. We'll give them like a diphenhydramine, and then we'll give them the Ativan, and sometimes we'll give them, something else to kind of help them relax a little bit. But the big thing about all of these is they are a controlled substance. You do have to have a authorized prescriber for them. They actually have to be prescribed on a certain type of prescription pad as well. Or they have to be electronically sent to the pharmacy with a certain designation. So I can write for these medications. I have designation under my DEA to write for these medications, but a lot of providers have decided to not write for these anymore because there's a lot of liability associated with them, because there's a high incidence of mixing these types of medications with alcohol or other types of drugs and potentially seeing patients overdose. So a lot of people are staying away from them. The best way to treat anxiety, the number one way to treat anxiety, is through cognitive behavioral therapy or some type of therapeutic management. Therapy is the number one way, talk therapy. Now, medication, yes, we want to use medication to support the patient, but we also don't want them to be on it long term because they're going to get addicted to it. Okay, so we use them for very short term. If I prescribe a patient over the course of a month an anxiolytic like a Xanax or a lorazepam, I'm only going to give them like 10 for the month. So they have to really choose when they're going to use it. And it truly needs to be for a definable reason. If the patient's having panic attacks or anxiety attacks or whatever the case may be. If you're having an anxiety attack every single day, then you need to be on something more chronic in nature. Okay, some kind of medication that can help you with more of the chronic types versus the panic attack. Okay, so big thing with that, benzos, highly addictive. Okay, and they are all used for acute anxiety. Great. All right, these are some of your other, there's some more PAMs. See all the PAMs there? Flurazepam, temazepam, triazolam, estalozam, clozapam, because those are all your PAM sisters. And again, all of these are considered controlled substances. So they all need to be done on a particular kind of prescription, on a triplicate prescription. Only one that doesn't, this is the only one that I can call in, right there, good old Valium. Okay, Valium is an old school medication. It's the only one for some reason that I don't need to have a triplicate prescription. I can call it in if the patient's really having a hard time on it, but it's an old medication. These are your short-acting sedatives or hypnotics, Ambien, Sonata, Lunesta. These are all your Z hypnotics. They all start with a Z, or they have an emphasis of a Z in them. So the zolpidem, zolapalon, and the zolpidem. I love all these commercials that you see, like Lunesta, will help you sleep like you're laying on a cloud, and oh, you'll get the best night's sleep you would ever have. But oh, guess what? Lunesta is also habit forming and addictive too. All right, so these also fall under a controlled substance category as well. Okay, so when we say controlled substance, it means that they are highly addictive, very easy to become addicted to these medications. So again, we want to be careful how they're prescribed. We don't want to do it on a long-term basis. We definitely don't want the patient to take them every day. I tell patients, if I'm going to give an Ambien, pick 2 or 3 nights a week where you know you're really going to have trouble sleeping, or you've been up for the last 2 nights, you can't sleep, take it on the 3rd night. But definitely don't take it every day because your body will get used to it. These are your melatonin receptor agonists, your buspirone, doxepin, and ramelrone. Buspirone, like I was talking to you guys about chronic anxiety, buspirone is one of the few anxiety medications that we have that is not addictive in nature. Okay, buspirone is actually prescribed quite a bit for patients with chronic anxiety and irritability. I'd say 1 out of 2 patients that I prescribe for will get buspirone. And it helps. It's not addictive in nature, which is the first thing that I'm pleased with. Bummer about it, you have to take it 2 times a day for it to work. It is a titrated medication. It starts anywhere from 5 milligrams BID all the way up to 30 milligrams BID, depending on how the patient reacts. Most patients will tell me what buspirone does is it makes anxiety a lot more tolerable. It doesn't take it away, but it's a lot easier to tolerate the anxiety that's occurring. It's more for like chronic anxiety and irritability or agitation. So if you're just one of those people that just always feel like, just always like, just irritable and angry, this is usually a medication I'm going to consider for you. Okay. Big side effect with these medications, all your psychotropic medications, number 1 side effect with psychotropic medications, gastrointestinal upset, GI upset, diarrhea, nausea, vomiting, nausea especially. Okay. So what do? How do we curtail that? With most of the medications, I actually tell patients to take it with food, because then the medications will absorb at the same time the patient's digesting. If they take medications without food, it's going to absorb into the gut really quickly, and it's going to cause increased peristalsis. So I really always, most of your medications, probably 80% of the medications that are prescribed for psychotropic means really do need to be taken with food. Okay. Number 1 is gastrointestinal upset. Number 2, lethargy, sleepiness, feeling groggy, feeling just kind of out of it. So lethargy is number 2. Number 3, sexual side effects. Okay. All right. Your TCA.
Sexual side effects?
What's that? Sexual side effects, yes. They all have, if you look at the side effects, I mean, literally every side effect you could possibly ever think of is in there. I have a patient today who had tinnitus. So her ears are ringing more now that she's taking it. I have another patient that said that it gives him hot flashes. Another patient was saying, some of the medications, like the antipsychotic medications, will cause an increase in male breast tissue. So, I mean, honestly, I'm just giving you a list of what you would potentially see. But for the most part, number 1 and number 2 definitely are going to be GI upset, lethargy, and then sexual side effects creeps in there too. Okay, but there's all sorts of potential side effects. If you ever watch like the commercials that come on about psychotropic medications, you kind of sit there going, why would someone take this? There's so many possibilities of bad side effects occurring. So yeah, that can happen as well. Nortriptyline, amitriptyline, and imipramine, these are your TCAs, or your tricyclic antidepressants. The difference between your TCAs and your SSRIs. Somebody tell me the difference between TCAs and SSRIs. Let's see. Let's give somebody else. Samantha, what do you think? And I don't expect you guys to know, but I'm just going to throw it out there, see if anybody knows any difference. What do you think the difference might be between TCAs and SSRIs?
I think they might, this is just a broad guess, maybe chemical compositions in your brain.
Oh, well, absolutely. Well, I think you're on the right track here. So TCAs and SSRIs, the goal is to help with the dysregulation of serotonin, right? And so we know that SSRIs are going to focus specifically on serotonin reuptake. So what we're trying to do is the ups and downs that occur when you have depression, and it goes up and it goes down, it goes up and down, is actually try to capture it with the installation of a medication that will actually help balance the dysregulation, so the ups and downs. So what we call a reuptake inhibitor, we're helping it from it going up, we're pulling it back down. So we don't want the reuptake to occur. We want it to be balanced. We want it to be across the board, so we're not seeing the ups and downs of it. So an SSRI grabs it and pulls it back down. A TCA is going to look at the chemical components associated with, it's in 3 different broad spectrum compounds. But the big difference between the two, TCAs and SSRIs, is side effects. SSRIs have a lot less but you're on the right track, because you're right, it has to do with the chemical compounds associated with the two. But the big piece between the two, why we're going to go to SSRIs before we go to TCAs, is the amount of side effects associated with an SSRI are far less than traditionally than with TCAs. So you're going to see a lot more potential side effects with TCAs. So we try SSRIs first before we get to a TCA, and you'll see if we go to SSRIs, can you see all, I'm sorry?
I've heard that sometimes you could use one to kind of counteract another, like they'll use the Wellbutrin to counteract the side effects of like Effexor or.
Absolutely. Absolutely. Yes. Great answer. So yes, you can use an SSRI with an SNRI or a TCA to a lesser degree. Your goal is going to, like, if I'm going to prescribe Wellbutrin or bupropion and I'm going to prescribe, let's say, sertraline, I'm going to probably prescribe higher doses of the SSRI because the focus is the depression, but the Wellbutrin, which is an SNRI, is going to be more focused on norepinephrine, which is that fight or flight response. But you can't treat stress and anxiety without treating depression. So the goal is to kind of offset, like you were saying, Samantha, to be able to balance them out. So it does potentially decrease some of the side effects that can occur from the medications, or one can target one neurotransmitter more so than the other, so that you have a duplication of both. Because the goal is to treat the SAD triad, which is stress, anxiety, and depression. They all go together. So if we can treat the stress and anxiety with the SNRI, which focuses on norepinephrine, and then treat the depression with the SSRI, which focuses on the serotonin, that we're treating both. Does that make sense? Am I blowing your mind here, guys? Not trying to, but we'll open this up, okay?
Kind of cool.
Okay, good. So these are your SSRIs. Your fluoxetine Prozac is the #3 medication prescribed in the United States. #3.
Which one?
Prozac. There was a movie called Prozac Nation that just focused so much on the fact that so many people are on Prozac. Sertraline is crawling up there. It's coming in. I prescribe probably sertraline more than I do Prozac. I just find that it has less side effects, and sertraline can also be used to treat PTSD. So I have a lot of vets, so I treat a lot of patients with with sertraline. Paroxetine is Paxil, citalopram, Celexa, Scatolopram, which is Lexapro, and then fluvoxamine, which is Luvox. These are some of your SSRIs. These are SNRIs that we were just talking about, Sam, that you had brought up as well. Things like venlafaxine. I swear by venlafaxine. For my patients that do not react well to SSRIs, they seem to do really well with Effexor, with venlafaxine. You got to watch a little bit more carefully. Sometimes the patients with on venlafaxine have a tendency to gain a little bit of weight. So I have patients that don't. What's that?
My husband was actually on that, and he gained 30 pounds, and he had every side effect under. And yeah, so he had a really hard time on that one. So then he switched to the Wellbutrin.
Mm-hmm.
So he's kind of navigating that, but that.
Yeah, that's the only thing that's a big one with the Effexor, is it does work for a lot of people, but that weight gain is a little bit challenging.
For a person getting that much weight, they will get depressed just by that.
Exactly. Yeah, that doesn't help very much. Exactly. Yeah. I will sometimes, if I have patients that don't do well on an SNRI or on an SSRI, I'll go to tofranil. I'll go to topiramate, this one right here, or imapramine. It's the only one. Interesting thing about this, it's the only antidepressant that people actually lose weight on. And that's the tofranil. It's the only one. All the other ones, potentially patients will gain weight on, but for some reason, imapramine, the way that it reacts, it precludes the dopamine, which is our like, ooh, chocolate tastes good. I like it. It's hitting my dopamine receptors, and ooh, I want more. Whereas toperamine or topiramine or imapramine, it curtails that. So a lot of times people actually have less of a desire to eat. It's the only one though. So sometimes if I have patients that gain a lot of weight on an SNRI or on a SSRI, I'll try them on toferenil. And then this is SNDI, which is the serotonin norepinephrine disinhibitor. This is mirtazapine or Remeron. If you want a patient to go to sleep, give them mirtazapine. Mirtazapine. Every single time I give a patient mirtazapine, I always tell them take it at night because you're going to sleep with this stuff. And it's condensed. So the lower doses actually cause patients to sleep more. So if I have like a patient on 7.5 milligrams, if I bump them up to 15 milligrams to help with their depression, sometimes they'll say, I slept better on the 7.5 milligrams. So it's really interesting how the body reacts. But mirtazapine, Remeron works really good. It's a good medication for depression, but you got to take it at night, and it does make people really sleepy. And sometimes, you know, if you're a person that goes to bed late, has to wake up early, this is not the medication for you because you'll go to work groggy. You got to give yourself at least 8 hours to sleep on this.
I have 2 questions, if that's okay.
Yeah, please.
For melatonin, because like I think the max on like the bottle I have says like it's for like 30 milligrams. And I asked, like, I don't know why at some point I thought like each gummy was like 5 instead of 10. So I realized that I was taking, what was it?
50 milligrams?
Something like that, yeah. And I'm like, I couldn't sleep because of that. Is this a similar effect?
Absolutely.
So much it doesn't work versus like if I just took like 1 or 2, it works better.
What it is it's almost like with certain medications, even if you continue to maximize them, they're only going to hit a trough at a certain level. So the maximum that your brain can actually intake or the chemical response is going to have is going to be 30 milligrams. Even if you go higher than that, it's not going to do anything. If anything, it's more like a placebo effect. But it's not going to do anything after 30 milligrams. Your brain cannot saturate. It cannot provide the electrical impulses it needs depending on how much you're taking in, more than that 30 milligram dosage.
Okay. And then like the second question I had with a lot of the antidepressants, like while doing the med cards, I noticed like the warning was like for like suicidal ideation. And is it because when patients are taking antidepressants, because when you're depressed, you don't have energy and no motivation to do things. So you're taking an antidepressant, it would make you more energized. And if the patient, when they're depressed, the reason why that they haven't committed suicide yet, because they don't have the energy or motivation to do it. So when you give them the antidepressant, they now have the energy to carry out like these thoughts, if that makes any sense.
That's interesting. That's an interesting thought process. I hear where you're going with it. I had a patient took his life this week, and it hit me pretty hard because I only saw him once. He came in actually for a letter for court. He wanted a letter that said that he didn't need mental health treatment. He hadn't been seen in 5 years. He came in to see me and asked me for a letter for court to say that he was stable and he was no longer in need of any mental health treatment. And I told him, I said, I can't write a letter like that for you, because this is the first time I've seen you. This is the first time I've assessed you, and you haven't been seen in 5 years. So the only thing I can say is the last time you were seen before today was 5 years ago. And that according to what I see today, based on my limited experience with you, I don't think that you're a danger to self or danger to others based on my limited experience with you. But I cannot attest to whether or not you are stable. I can't, because we don't have enough of a relationship. And unfortunately, the next day the patient took his life. And that was really hard for me because you sit there and you think, okay, what did I miss? What could I have done different? What could I have said different? And what he presented to me was 100% different than what was actually happening. My first question under subjective for chief complaint was, patient is here for a letter for family court, states, quote unquote, I'm doing great. That's it on my actual chart. And progressed to ask him, I did a Columbia suicide risk assessment, nothing there. Oh, I'm taking care of myself with diet, with exercise, I take vitamins, I have family support, I don't need mental health treatment, I don't need medications, I don't want therapy, I'm doing great. And the next day he took his life. And what I will tell you is, although our goal is trying to intercede so that patients don't do that, the reality is that when patients want to do something, sometimes there is very little that we can do. We can try and curtail this. We can try and do our best. But if a patient has that thought process and we're unable to reach them or get to them or help them through this time in their life, then sometimes there's nothing we can do about it, because the patient truly feels that they are so desperate, they're going to do this. Come to find out, he had tried to kill himself 7 times the year before in front of his kids. And the reason he needed a letter for family court was because his wife took his kids away from him. So I'm not dissuading what you're saying, but the concern when you hear things or when you read your stuff for your med cards and it says, and watch for suicidal ideation, the reason is because you're introducing a new drug to them. And you may have a patient that's 200 pounds that you give 20 milligrams of Zoloft to, and they are spinning out of control with this. They're like, oh my God, my brain is moving too fast. I can't think. I feel really awful now. This stuff is terrible. I don't like it. Or you can have somebody that's 110 pounds that you give 300 milligrams of sertraline a day, and they go, this stuff doesn't touch me. Might as well give me a glass of water. The issue is that everyone potentially is going to respond to the medications differently. We all have our own chemical makeup of how our brain reacts. So the concern is when you introduce an antidepressant to a patient that's had long-term depression, you're changing the chemical responses that they have to a normative action that they usually do. Does that make sense? It's like you're basically dousing this fire, but it's shocking. It takes about 2 weeks for medications to start working. This is kind of something you guys should know. So psychotropic medications take about 2 weeks to work, and then about 6 to 8 weeks for you to feel the therapeutic response. So meaning the best they're going to work is going to be between that 6 and 8 week period. But in the meantime, we're titrating medications. I'm having the patient come back to see me in 6 weeks to say, hey, how you doing on the medication? Patient goes, you know what? I'm okay. I feel a little bit better. I think it's helping a little bit. Okay, that's enough for me to say, okay, we need to start titrating the medication higher because you're having some response that's positive. So we need to start titrating medications to a higher dosage for you. Or they come back and they go, I'm on this stuff and I'm just sleeping 12 hours a day. I can't do anything because I'm sleeping all the time. Okay, we need to lower the dose on it. So a lot of it is going to be dependent on how the patient reacts to the medications individually, but it's not a one size fits all. And so part of it is getting the patient to buy into it and knowing that, yes, you are changing their chemical responses to something that they've been dealing with for a long time. And the hope is to get them to a stabilized place. And most patients that start on antidepressants or on anxiolytic agents have to be on at least 3 to 4 before we find the right regimen for them. Like you were mentioning, Sam, like, it didn't work with the first medication. Now you got to try something different. But it's just finding the right regimen for the patient and getting the patient to buy into their plan of care that hopefully will find the right regimen for them. Does that kind of make sense?
A little bit, yeah. Thank you.
Yeah. It's not, I can't say that you're not, you don't, there isn't some validity to what you're saying, but whether you're depressed or not, and when you're in that really, really dark place, you're right. A lot of times they don't have the motivation to do it. And so you'll see when patients start and to make a decision, whether they're on medication or not, what you'll see is when people make a decision to actually take their life, they actually start doing very positive things. They'll start giving away their sweaters. They'll start giving away their mementos. They'll start, talking to people they haven't talked to. So basically closing the door, saying goodbye to people. And it's almost like they become euphoric because they've now have a plan to end their suffering. So it doesn't take medication to get them to that place. It just takes the fact that finally I can end my suffering. And unfortunately, it ends in some really sad situations that we don't want to see, that we want to curtail. But it doesn't mean that because they're on medications now they have the momentum to do it. If a patient wants to do it, they're going to do it. And it's very sad. And the goal is to try and intervene before they get there.
Okay.
Thank you for that question. A really good question, though. Okay, Our other antidepressant drugs, we mentioned them, bupropion or Wellbutrin. We also use this, just so you guys know, we use it for smoking cessation. It's the main derivative or drug utilized in smoking cessation medications.
I have seen that in the hospital with
Yeah.
patients.
Yeah, we use it for a lot of patients, particularly because patients with psychiatric disorders have a nicotine receptor that is very, very volatile. It's very reactive. So you'll see a lot of patients with psych issues are also chronic smokers as well because of the nicotine receptors in their brain. Trazodone is a great medication if you want to put people to sleep. It's a really good, I actually think it works better as a hypnotic than an antidepressant. I use it to help people go to sleep at night. It's a dose anywhere from 25 to 200 milligrams a night. Your mood stabilizers are going to be like your lithium. Lithium is your go-to mood stabilizer. Number one mood stabilizer that patients are put on first. These are for patients with bipolar disorder or a mood disorder are going to be lithium. Some of your other medications, if lithium is not effective for the patient's mood disorder, are going to be your anticonvulsive drugs like Depakote, carbamazepine, lamotrigine, gabapentin. Gabapentin's weird. I don't love it. We use gabapentin for everything. It's like throw it at the wall and let's see how it works. We use gabapentin for everything from neuropathy to alcohol abuse disorder to anxiety to sleep-wake disorder to insomnia. I mean, it's like, let's just, we don't know what else to use. Let's try gabapentin.
A lot of diabetic patients.
Neuropathy.
Like almost every patient has that one.
Yeah, we use it a lot for neuropathy.
I have a friend who has nerve pain from shingles, and they're taking gabapentin for it.
Yeah, absolutely. It does help, I think, really well with nerve pain. I don't think it works that great for anxiety, but you know, if it does, great, we'll try it. And then topiramate, oxycarbamazepine as well. Okay. Our antipsychotic drugs are broken down into first generation, second generation, and third generation antipsychotic drugs. They are strong antagonists that bind to the D2 receptors. They have blocked the attachment of dopamine. They reduce dopaminergic transmission. Dopamine is one of your major neurotransmitters associated with psychotic disorders, particularly disorders that involve audio or visual hallucinations, like schizophrenia or schizoaffective disorders and things like that. So your dopamine transmission is then reduced because there's a surplus of dopamine in patients that have psychotic disorders. So
what is schizoaffective? Because I saw that in one of the patients and I'm like, I have seen a schizophrenia, but not a schizoaffective. So I was like, what is that?
It means that they may not have necessarily profound hallucinations, but they have delusions. So maybe they don't hear or see things that are there, but their affect, how they are, how they react or they carry out in public is odd and peculiar because they may be delusional in their thinking. They think like there's a lot of like magical religious kind of stuff that patients with schizoaffective disorder have, where they feel like they're someone they know or they themselves or some kind of religious deity. They're not hearing things, they're not seeing things, but they have these delusions about themselves or other people. So they may be delusional in their thought process.
Yeah, the patient was like that. It was like not there, and he started talking about different things, but not like a reality. It was more like random things.
Yeah, odd and peculiar as well. Exactly what you're saying. Our antagonists for the receptors are acetylcholine, norepinephrine, and histamine. These are the antagonists for the receptors. FGAs, first generation antipsychotics, you'll notice that we use them for patients who've had long-term issues with schizoid types of disorders or psychotic disorders. We try not to use first generation antipsychotics as much anymore because there is some significant side effects. The big ones are weight gain and sedation. When I say weight gain, I'm talking 50, 60 pounds sometimes. It's unfortunate because the medications really help them, but it really does a job on their self-esteem. So patients will come back and go, I feel great now. You know, I'm not hearing or seeing things. I'm not delusional, but I was, 180 pounds and now I'm 250 pounds and I feel terrible and I can't see my penis anymore and I can't have sex anymore and I just feel fat and ugly. So take me off of this stuff because I don't want it. And what are you going to say? It's like, I get it. I hear you. It's terrible. And so sometimes we have to try different types of antipsychotics, but that's the big piece, that why we don't prescribe first generation antipsychotics that much anymore, because there's a high significant weight gain and sedation associated. Second generation atypical antipsychotics are used more. They produce fewer side effects or extrapyramidal side effects. The extrapyramidal side effects are a lot of those same side effects that you potentially would see that have some of the Parkinsonian types of symptoms. The shuffling, the pill rolling, finger rolling like this, the popping of the mouth makes your mouth really, really dry, really dry. You can have both negative and positive symptoms. I'll talk to you about that a little bit later. And it's often chosen as a first-line treatment because of cost and because of the amount of side effects are much less significant in the second generation antipsychotic. They're also associated with dopamine and serotonin blockers, just like we were talking about earlier. So these are some of your SGAs: risperidone, quetiapine, olanzapine, ziprasidone, clozapine, olanzapine, and ziprasidone. Those are your big ones that cause weight gain, a lot of weight gain. I try really hard not to prescribe them, but sometimes, and I'll prescribe more than one. I may have to prescribe Seroquel and olanzapine. So you've got a double dose of the patient potentially gaining a lot of weight. And so we try to be cognizant about prescribing it. Sometimes if I can, I'll prescribe quetiapine and then a really low dose of olanzapine. Quetiapine, I will tell you, is interesting though. We're using a lot more for depression, particularly for medication-resistant depression. So maybe we tried SSRIs, SNRIs, TCAs, nothing's working for the patient. We may try quetiapine. And quetiapine is a good medication to use for medication-resistant depression, and you can use it by itself. You have to prescribe it in low doses, so like 50 milligrams, and we prescribe it at night because it makes patients sleepy. So it also helps patients that have insomnia, which a lot of patients with psychotic disorders have really bad sleep-wake disorders. So the quetiapine really helps with it. I think it works pretty good. And it's, of all of those, it's the one that has the least amount of side effects associated with weight gain. These are some of your other stuff: lorazepam, asenapine, Fanapt, and Invega. Paliperidone is interesting. We can actually do an injection of paliperidone, and it lasts a long time. But the best medication, the best for a psychotic disorder, is right there: aripiprazole, Abilify. I wish that patients could be on, all patients with schizophrenia or some type of schizophreniform disorder could be on Abilify, but there's a reason that they can't. Anybody want to take a wild guess why we can't put all patients on aripiprazole? Tiffany, what do you think? Take a wild guess. What do you think, Tiff?
Could it be because they have Parkinson's?
That could be. There could be some precursor or some kind of sequelae we'd be concerned about. Yeah, absolutely. That could be a reason, but there's another reason.
What about cost?
Oh, good girl. Who just said that?
Sam.
Who's that?
Sam.
Oh, good. Very good, Sam. Absolutely. 100% right. You're absolutely right. Sam, Abilify is very expensive. Aripiprazole actually also comes in injectable form. The patient that I have that to me typifies the most positive response to aripiprazole was a patient that was homeless. It was a vet who had come back from service, and she had severe mental illness. She actually served for about 6 months. And when she got home, she started on some fairly significant drugs, and she was psychotic and was living on the streets. Eventually, the town felt so sorry for her that they pretty much put in a collection for her, brought her to the VA and said, hey, this is a veteran. She's been living on the street. We want to help her because she's a really nice lady and we think, someone's going to hurt her. So she got into the system. She had already been on every kind of antipsychotic drug you could possibly think of. And we were able to actually qualify her to be on aripiprazole injectable. So she would get the aripiprazole injectable once a month, and then we would give her PO aripiprazole in case she had breakthrough like delusions or hallucinations. As of last year, she's living in a house. She's working as a housekeeper at a local hotel. She still hears voices and sees things that aren't there, but she can control it better. The medication's working really well. A 1 dose of aripiprazole injectable is about $5,300. So if you look at that over the course of a year, you know, you're talking $50,000, $60,000 for this medication. So it is, unfortunately, it's not offered on a widespread basis. Insurance companies do not like paying for it, even if it's by mouth. It's a very expensive medication. But here's the cool thing. Every year I go to the APNA conference. I didn't get to go this year because of COVID, but every year I go to the American Psychiatric Nurses Association conference. And the last time I was there was a gentleman that was showing us an aripiprazole pump, which works very similar to an insulin pump. And they were actually able to show us what it looked like. And it goes just like an insulin pump. It would perfuse the medication systemically to the patient over the course of 24 hours a day. And once a week, they just have to switch out the Carpijet. But they had some really good, promising anticipatory types of medications that I think will be available, hopefully, and not cost an arm and a leg, and more patients will be able to get it. So keep your fingers crossed, you guys. Okay. All right. These are some of your other medications. We're not going to get into this too much, guys, because we'll be going through it as we go through each section specifically regarding these drugs. ADHD disorder, we know that this is a disorder usually of children and adolescents. We use stimulants for treatment of these patients, things like methylphenidate, which is also known as Ritalin, dextroamphetamine, which is Adderall or Vyvanse, atomoxetine, which is Strattera, Intuniv, which is guanfacine, and Catve, which is clonidine. These are just some of the medications. We'll get into this a little bit more when we go over adolescent disorders, but these are some of the medications. These are all stimulant medications because they are stimulants and they are used for this type of disorder. They're also categorized as controlled substances. So stimulants are considered a controlled substance because what happens if they get onto the street? What do we do if we cut up this methylphenidate and we just make it meth? Well, it gets cut into other drugs, and unfortunately, it is one of the main compounds in methamphetamines, specifically meth that's used on the street. So we have to be really careful with it. It's very addictive, and it really needs to be prescribed for patients that have a diagnosis of ADHD. Alzheimer's disease, we use medications that are specific to, there is no cure for Alzheimer's, guys. There's the medications that we use are medications that will help slow down the progression of the disease. The big one that you're going to see a lot is going to be Memantine or donepezil. Those medications are designed to curtail the advancement of the disease. Herbal medicines, we had to be careful of major concerns with herbal medicines. Okay, so dig on this. So about 30 years ago, in Scandinavia, they came out with this miracle medication that we could start taking, that we didn't need to use antidepressants anymore. We didn't need to use SSRIs or TCAs or SNRIs. There was this miracle herb that they found that was going to just wipe out depression, and it was over the counter. It was easy to use, and people were having great reactions to it. And this was like 30, 40 years ago. The medication was known as St. John's wort. St. John's wort is still sold over the counter. A lot of people still swear by it, they use it, but something happened. What we found out was through long-term use of St. John's wort, it had the same chemical effects on the body as, guess, anybody know? Coumadin. Same chemical responses in the body as Coumadin. It thinned our blood out. So we found out by means of the fact that patients were going into surgery and bleeding out in surgery that they were taking, oh, it was just an herb. It's just the stuff I take from Save-On. It's not a big deal. And found out, wait, hold on a second. It's affecting your coag factors. So it didn't end up being what we thought it was. People still use it, but we do suggest that people don't use it on a long-term basis and give themselves what we call medication holidays, where they can go off of it for a while. Can cause liver and kidney damage over long-term use. Things like medications with like black licorice in them, or certain types of like derivatives, not like licorice that you eat with candy, but certain types of derivatives like St. John's wort and other types of hallucinogenic medications can cause damage. So we got to be conscientious of what we put in our body and what the potential side effects are as well. Okay. In a person who has decreased circulating levels of GABA, I'm gonna have somebody look this up for me. Nancy, why don't you look this up for us? A person who has decreased circulating levels of GABA, which health problem would be expected? So that'd be Alzheimer's, Parkinson's, anxiety, or insomnia. Or does somebody want to take a gander at that one? What do you guys think?
Doesn't GABA and Parkinson's go hand in hand, kind of like?
Very good. So it's not Alzheimer's. Parkinson's, yes, can use GABA. Parkinson's has to do with dopamine and GABA as well, because it's a minor transmitter too. But GABA is actually also associated with anxiety disorders. So if you said B or C, you would be right. B or C were right. But yes, Parkinson's and anxiety disorders. To some extent, it sort of creeps in a little bit with insomnia, but it's not one of the major issues associated with decreased circulating levels. So yes, either Parkinson's or anxiety would have been accepted. All right, nice job, you guys. Good job. Which neuroimaging technique would reveal problems in the anatomical structure of the brain, but not problems in function? Would that be a CT, a PET, or a SPECT?
CT?
Hey.
Yeah, CT. So we can see structure, we just can't see tissue. All right, nice job, you guys. Okay, let me go ahead and stop this recording. Okay, so looking at just some of the...
Dr. Marquez, I'm sorry, are you recording this?
Yes, ma'am, I am.
Oh, thank you.
Just put it on right now.
Oh, thank you.
Thank you for reminding though. Okay, so if we look, can you guys see the screen though? Yes, you can see the neurotransmitter?
Yes.
Okay, awesome. All right, so we look at how chemicals in our bodies impact our behaviors, and psychologists study the brain and the nervous system to look at biological functions, underly human behavior, and in order to form a full understanding of ourselves. Okay, so let's go into this. We know that in our nervous system, which is comprised of our central nervous system and our autonomic nervous system, our CNS, is our brain and our spinal cord. We have about 1 trillion nerve cells in our body and 100 chemicals that transfer messages between our nerves. These chemicals are called neurotransmitters. These are the major neurotransmitters associated with mental health. Okay, so we know that the nerve ending is where the axon is, and the outgoing messages are coming through the axon. The neurotransmitter itself is the chemicals that travel between the neurons, or that little gap in between. And then the nerve ending, which receives the incoming responses, okay? Neurotransmitters stimulate the nerve endings or transmit electrical impulses from the brain to the body. So looking at this is a good slide. Please look at this slide. Important, 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 okay? If you want to know what my neurotransmitters are and what they do, this slide is actually in your files, and it's under biology of neurotransmitters. So look under files. It's there for you. But look at this slide, because it's going to tell you everything you need to know. Okay, so acetylcholine is one of our major neurotransmitters. It is responsible for movement control, thinking, and comprehension. Okay, so we know that acetylcholine is potentially going to be involved with things that may respond to movement control, right? So we know that Parkinson's disease, some of your neurocognitive disorders have a direct relationship between the transmission of acetylcholine. Glutamate is responsible for memory. GABA is responsible for eating, sleeping, and aggression. Now you will notice that there are some cross areas where movement is in more than one area of neurotransmitter functioning. Dopamine is responsible for movement control, attention, pleasure, and rewarding feelings, okay? Serotonin is responsible for eating, sleeping, mood, pain, depression, and coping with stress. Endorphins, like norepinephrine, are responsible for pain suppression, pleasurable feelings, and appetite. So endorphins is also norepinephrine, okay? So this is your little neurotransmitter slide. I put that in for you for easy access to take a look at and go, oh, wait, what's glutamate responsible for again? Oh yeah, memory. I know that potentially glutamate is going to be responsible for something like organic brain syndromes, that we know that it also has to do with the reuptake for patients that are reuptake of the particular electrical transmission that occurs with patients that have things like Alzheimer's disorders, okay? Neurotransmitters look at an excess, pardon me, or lack of neurotransmitters that can impact behavior. If we look here, the transmitting neuron is transmitting the dopamine through the synaptic gap into the receptor cell in a healthy patient. Here, the transmitting neuron is depleted of the amount of dopamine, and thus the receptor cell is getting less of an electrical impulse of the dopamine, okay? For example, Parkinson's disease causes the brain cells that produce dopamine to die. The lack of dopamine in the body leads to shaking, irregular movements, and loss of muscle control, of motion control. Lack of dopamine also depresses your mood, which affects your personality and habits. This just kind of goes through each one of the neurotransmitters. So we know dopamine is associated with motivation and reward. So you're looking at something like this for patients who have things like alcohol abuse disorder or substance abuse disorder. It's a dysregulation of dopamine because it's that pleasure principle. It's the pleasure that they get from drinking alcohol or smoking pot or using an illicit substance that gives them that high that increases the amount of circulating dopamine. So it has a direct effect on the transmission of dopamine. Too much is also bad. Studies show that unusually high amounts of dopamine in our bodies is also related to things like schizophrenia. This looks at certain drugs like cocaine cause a temporary overproduction of dopamine, mimicking the reward sensation. In other words, cocaine gives you a greater feeling of reward than the things that naturally cause dopamine production. And the result of this is addiction. So we know dopamine is directly related to addictive disorders. Endorphins like norepinephrine give us, are released when we exercise or also when we experience pain. Some people who engage in self-hurting behaviors may do so in part to feel a feeling of euphoria prompted by controlled amounts of self-inflicted pain. They block pain into our body and are also responsible for feelings of pleasure or happiness. Lack of endorphins may be responsible for certain forms of mental illness like OCD as well. Acetylcholine is involved in control of muscle movement, learning, and memory function. A lack of it causes uncontrolled muscle movements and difficulty forming and retrieving memory. Serotonin is a neurotransmitter greatly involved with your mood. If you're feeling pessimistic, sad, distrustful, unconfident, or have panic attacks, you may have a serotonin deficiency. Okay. Anyway, I wanted to make sure that you guys kind of took a look at this, have an idea of some of the major functions of the neurotransmitters. There's not all of them, but it gives you sort of just a generalized discussion associated with it. Okay. And this talks about your PET scans that we looked at a little bit earlier. This is being able to actually see the tissue itself with the PET or the SPECT scans. You can see the activity that occurs. Look at a healthy brain. There's lots of activity, lots of movement in areas that are red, and you can see like a healthy transmission of neurons firing and so forth. And here you see very little brain activity in an Alzheimer's patient. Okay, so that's for you guys to take a look at. That's under, again, biology of neurotransmitters. Or I think it's just biology. What is it? I think it is biology of neurotransmitters. Okay, so that slideshow is in there for you guys too. All right, and we're gonna look at one more piece I'm gonna show you guys. This is, we're doing 6. Okay, so we need to start talking about the legality aspects. Stop this share for a second. When we talk about the legality aspects, it is really important for us to take this into account, because what you have to remember is just because a patient is in a facility or in a mental health hospital does not mean they lose their rights as a human being or as a citizen or as a patient. If a patient tells you they don't want medication, you have no right to force a medication on a patient. Now, there is a little bit of a caveat to that, and I just have to be able to express this to you because it's important. if a patient is causing harm to someone else or harm to themselves, you can potentially medicate a patient if they are in a situation where they are going to be hurting you or someone else, because of the fact that we have to curtail this behavior. However, you better have some substantiation behind it. It can't just be, I didn't want to handle this patient today because they were being really just annoying and irritable. There has to be some substantiation behind it, and you better be able to stand up in court about it if you ever get called in, because if you do something against the patient's will, it is considered battery. You are doing something that the patient is not asking for, is saying no to, and is refusing. So there has to be substantiation as to why you give a patient Haldol, or why you gave a patient an Ativan, or whatever the case that you gave them, if the patient is screaming and hollering and saying no. Now, if they're throwing things around the room, or they're, you know, fighting you, or they're hitting you, or they're coming at you with a knife, and your partner's behind you, and you know, we're saying we're going to give you medication to help you calm down, the patient's screaming no, your partner gives it to them, that is substantiation, because they were physically being volatile, they were going to be violent. That's a substantiative reason as to why to do it. But for the most part, other than in really specific circumstances, we cannot make a patient do anything they're uncomfortable with, or make a patient do something we want them to do if they're refusing to do so. Okay, so let's take a look at that. Let me go into, downloaded a whole bunch of chapters for us. I don't have to keep looking for them, but no, okay, there it is. Okay, so let's take a look at the legal aspects of this. Let me share my screen with you guys. Okay, so not only do we need to look at this from a legal perspective, but we need to look at this from an ethical perspective as well, guys. Okay, so let's take a look at this and see what it says. If we, from an ethical perspective, look at the treatment of patients, not just mental health patients, but patients in general, we are going to implement concepts associated with ethics and morality. Yes? Okay, so we want to look at things like ethics, bioethics, and the ethical dilemmas that can occur. Things like the study of philosophical beliefs about what is considered right or wrong in a society is ethics. Bioethics is used in relation to ethical dilemmas surrounding healthcare. So next semester, you guys are going to be at ethics with me. And that's pretty much the whole course, is exploring ideology and understanding associated with the study of philosophical beliefs, as well as ethical dilemmas that occur in healthcare. An ethical dilemma that is a conflict that occurs between two or more courses of action, each with favorable and unfavorable consequences. So we called it the cost versus benefit analysis. Is the cost worth the benefit, or is the benefit worth the cost? And that's sort of identifying the favorable or unfavorable consequences that can occur. So these are some of your 5 principles of bioethics. This is all we learn in ethics next semester: beneficence, autonomy, justice, fidelity, and veracity. These are all concepts associated with good nursing care, providing good care to patients, understanding that we need to promote good, we need to respect the rights of others to make their own decision, we need to distribute resources or care equally. I wish justice was more equally served though, because if you look at the differences between hospitals, you can see that there can be some major differentiations between them, particularly in mental health. Fidelity is maintaining loyalty and commitment to doing no wrong to a patient, and veracity is one's duty to always communicate truthfully. There are civil rights for persons with mental illness, and they are covered under federal and state laws, and they're guaranteed the same rights as you or I who don't, quote unquote, have mental illnesses. This looks at due process like the writ of habeas corpus and the least restrictive alternative doctrine, meaning that if the patient has a serious mental illness, but is not threatening you or threatening themselves at time of care, there is no reason to medicate the patient. There's no reason to do anything acutely to the patient if they're in an environment that supports that milieu environment and they are safe, and there's no reason to do anything against their will. There are 3 types, well, there's a couple different types of admissions, but let's take a look at these three types. An informal admission to a hospital is sought by the patient. Maybe the patient is at home and they have a plan, they have intent, they are going to carry out something that potentially is going to cause them to do something self-inflicting to themselves. So the patient goes, before I do that, I got to get some help. So the patient themselves goes to the hospital and informally is admitted as they themselves as a voluntary admission, but this is something that they themselves are seeking. This is incorporated with a voluntary admission because it is sought by a patient, but a voluntary admission can also be sought by a guardian. Okay, so it means that a family member, someone who has direct oversight over a patient, has the opportunity to take the patient in for a voluntary admission. Same kind of criteria as an informal, but this also involves a guardian as well. Temporary admission is the person who's confused or demented. So maybe you have a patient that's on the street that has Alzheimer's or has dementia. It doesn't necessarily belong in a mental health facility per se. Maybe they belong in more like a long-term facility, or maybe they wandered from home and they're walking around in the street. You've got to put them somewhere to be placed until they can be retrieved or they can get back to their original destination. Or so ill that he or she needs an emergency admission. Okay, and that was like that patient that was gravely disabled that I explained to you about, that had defecated and urinated and hadn't eaten and hadn't drank anything, so didn't reach any of those Maslow hierarchy of needs associated with his care. Involuntary admission is without the patient's consent. This means that the patient has usually been brought in by emergency medical personnel like EMS. They're transferred from a higher level or another level of care like an emergency room that doesn't have a mental health facility. There are long-term involuntary admissions that require medical certification. They also require review by a judge, and it also has to have administrative action associated with it. And then involuntary outpatient admission. That would be something like a daycare type of thing. So let's say a patient was remanded to rehab and the court said they have to check into rehab at 8 in the morning and they can leave at 8 at night. That's involuntary outpatient because they can go home at night, but they're required to go in for alcohol abuse or illicit drug use rehabilitation. There are 3 types of discharges. There is a conditional release, an unconditional release, or release against medical advice. A conditional release would be potentially that the patient has to follow up the next day. Maybe they have to report to like Alcoholics Anonymous or a 12-step program, or they have to report to some type of outpatient rehabilitative facility. So they're allowed to leave, but with a caveat that they have to also do certain types of support services. Unconditional release means that they let the patient go home and they're not required to have any additional support or care after they leave. And then an AMA, which is obviously the patient is release against medical advice. Patients have the right to treatment. They have the right to refuse treatment. If it's a patient who says today they don't want to take their psychotropic medications, or they don't want to have ECT, they don't want to have electrical convulsive therapy that day, or they don't want to be a part of group that day, the patient has the right to refuse. They don't have to if they don't want to. We don't have the right to make them as well. They have a right to informed consent, to know what their treatment is going to be done. Just like any other patient, guys. If you're going to go into surgery, you have to explain the procedure, what's going to happen, where it's happening, who's doing this particular procedure. So they have the right to be informed about the procedures that they're going to be going through. Let's look at this case study. Okay, so we have a patient, 27-year-old male, is court committed by his parents to your unit with a diagnosis of paranoid schizophrenia. He lashes out at staff when they attempt to give him his medication. He states, "You are trying to poison me." His family asks if you can force him to take the medication. What do you think? What do you think, Tiffany T? Can you force him to take his medication? Tiffany Trinidad, are you there?
Yeah, sorry, my mic was muted. No.
Nope, how come?
Well, it says he lashes out. Does that mean like he was being violent or like verbally? If it was physically, then maybe. But if
But it says when they attempt to give him his medication, so it's not like he's doing anything at them. It's just when you try to give him the medication.
Oh, okay. So yeah. So if he's not lashing out physically, then you can't. But if it was physical, then like if he was being violent about it.
Yeah. So the reason that he's lashing out is because they're trying to give him his medication. So if he, like you said, if he was lashing out beforehand and he was aggressive or fighting or hitting somebody, then you would potentially it would substantiate you having to give him medication, to curtail his anxiety. However, in this case, no, he's lashing out because he doesn't want the medication. He says, you're trying to poison me. So it sounds like he's got some type of paranoid schizophrenia. But at the same time, we can't make him take it. You're absolutely right. You cannot force him to take his medication. Good answer. Okay. How would you respond to the family? Talk to me. What do you guys think? What would you say to the family? What would you say to the family if the family was concerned and they wanted you to force him to take the medication? What are you going to need to tell them?
Oh, you can tell them that is you cannot do that because the patient has the right to take or not.
Absolutely. Yeah, very good. The patient has the right to take it or not take it. It's completely up to them. So do you think the family is going to be happy with that response?
Nope.
No, they're not. They're not going to be happy. They're going to be really angry with you.
Question regarding that.
What's that?
So I have a question regarding that. The patient is 27, so it's like, can make his own choices. But if you have a minor, how would it be? Like, what will be the case there if it was a minor?
No, he can still opt to say no.
Oh, okay.
Yeah, just because his age is factored in. Now, obviously, the family is going to be more involved as well, but the minor has a right to say no. Unless, again, they're being volatile or aggressive, they can say no. They don't have to take the medication as well. It's hard to be in that situation because it's best for the patient to take their medication, but it's against the law. It can be considered battery if we make the patient do something they don't want to do. We can be held legally responsible. So we have to explain to the family, we're very sorry, we're trying to support you and support the patient, but the patient has the right to refuse. And I can't do this because it's against the law for me to make him do something that he's not comfortable with. And they don't like that answer, and even when I see patients, I'll have family members come in with them. And I always ask my patient first, do you want your family member in with them? And it's always interesting, especially with telehealth, when they both show up on the screen. And I go, can you give me a few minutes with the patient? I'll have you come back in a little while. And, the patient's family members always looking at me like, what? Because I have to ask them first, are you comfortable with this family member being in there? And sometimes the patients will say, no, I'm not. They always sit in here with me and I don't not want them in here with me. It can be challenging, but you have to make sure that you understand that your patient is your priority.
I have a question.
Yes, sir.
I've when I worked mental health module, you see some inmate that come in really super crazy. Like when I say crazy, I mean crazy. They eat their feces and they smash their feces everywhere, and they start cutting themselves with all kind of stuff. We put them on suicide gun and stuff like that, and they'll refuse to take the medication for days. And you see the nurses, the doctor, the psychiatrists tell the nurses to crush the medication and hide it so that the patient could take something. Is that ethical?
It's a good question. That's a serious mental illness. If you can get the patient to be reviewed by a judge to be considered incompetent, and the patient cannot make decisions for themselves, then you have a little bit more legal leeway with it. Most of the time you have to have that declaration before you can, and you have to have someone that's stated as a legal oversight for them, so that you can call them and say, look, the patient's being really volatile right now. They're eating their feces or they're throwing things or whatever the case may be. We want to give them medication. The patient is refusing. Do we have your permission to give them medication? Then you're going to who's ever been designated through the court as their decision maker for healthcare. At that point, yes, you could do something like that. but you'd have to have the patient declared incompetent to make their own decisions about their health care. So is it unethical? Yeah, kind of, if you don't have the legal statutes in place. But it's a fine line there, because the patient is doing something to harm themselves. They're doing something that potentially will make them very sick. But it's better to do it through legal channels and get the patient declared before you do something like that.
Would this still apply if a patient voluntarily signed themselves into a facility, into the care?
That's a great question. That's an awesome question. Okay, so a patient that comes involuntary can turn into an involuntary admission. Okay, so let's say the patient walks in and they're complaining or they're concerned that they might hurt themselves or hurt somebody else. And, they come in, they go, I'm not sure, but I'm just sort of feeling this way. The patient is assessed. The doctor or the provider says, I am concerned that this patient is high risk for a threat to self or threat to others. They came in as a voluntary admission. However, based on the patient's assessment, it is my assessment the patient needs to be held for 72 hours to evaluate their level of volatility. Okay, whether or not we really truly feel the patient's going to do something like this. Now, if the patient came in and they were talking to the doctor and said, I'm doing okay. I was just feeling really bad. I'm not going to hurt myself. I'm not going to hurt anybody else. Then that's totally different. Then the doctor may say, are you sure? I'm concerned about you. I'm thinking we need to keep you for a few days. And the patient can say, no, I have no will to hurt myself or hurt anybody else. I think I'm just going to leave. They can leave that way. And the doctor has assessed them and has felt that the patient is not a risk, then the patient can leave. However, if the doctor feels the patient is a threat to self or others, that voluntary admission can turn into a 72-hour hold. So it can turn from voluntary into involuntary, particularly if the patient says, no, never mind, I don't want to be here. And we ask the patient, do you still have intent to hurt yourself or hurt someone else? And the patient goes, well, yeah, that's why I was here, but I don't want to be here anymore, so I'm going to leave. Yeah, that's completely, the scenario changed completely. So yes, you can turn a patient from voluntary to involuntary.
What about in terms of with medication? So if a patient is voluntarily in a facility and let's say the doctor said they want the patient to stay there for a week to observe them, and they would take medication to help with their symptoms, and what if they refused the medication then?
Yeah, they can still refuse. Yeah, they have every right to refuse it still. Absolutely. We can't make them take it. It wouldn't necessarily change voluntary to involuntary regardless. If the patient is of sound mind and they're making a decision they don't want to take their medication, they have every right to exercise that right.
So what is leave against medical advice? What is the, I'm not exactly
that would
sure.
be, so and this happens a lot, particularly in emergency rooms or in triages and it's unfortunate because it occurs quite a bit in small hospitals or in hospitals that don't have mental health care facilities. So the patient will come in with, we'll bring them into the emergency department and will come in concerned either through the emergency department by EMS, or they'll walk in themselves and say, hey, I have thoughts of hurting myself or hurting somebody else. And the doctor assesses them and says, okay, we're going to transfer you to a hospital, based on what you've told us. And the closest hospital is 50 miles away and there's no beds. So we're just going to keep you in the gurney until a bed opens up. And then 48 hours, the patient's still waiting for a bed. The patient goes, you know what, this isn't worth it. I'm going home. And they'll sign out AMA. You haven't transferred them to a mental health care facility. So you haven't been able to actually admit them to a hospital that specializes in mental health. That would be an AMA. Or if the patient came to the facility and then was triaged and no one has done, the physician hasn't or provider hasn't done a full assessment, the patient goes, I'm tired of waiting, I'm out. And the nurse says, no, we really recommend that you stay. You haven't been assessed by a physician yet. The patient goes, nope, I don't want to wait anymore. I'm gone. That would be an against medical advice. Whereas we wanted the patient to stay. And that happens quite a bit, unfortunately, because the hospitals are so bombarded and they're so overtaken by patients that patients end up having to wait for hours or days to be assessed by a doc. They'll be seen by a nurse. The nurse will do an initial assessment, but the provider themselves, that will make the decision as to whether or not the patient gets admitted, takes hours. And so the patient will leave against medical advice. We had an event like that happened at the local hospital. The patient went home and took his life when he went home. And he hadn't been assessed by the physician because he was just tired of waiting at the hospital. So, and that does happen a lot, unfortunately. And it's because we don't have enough mental health facilities, and we don't, finding a bed for a patient is really hard to do sometimes. So it makes it really challenging. It's very sad.
Professor, I have a question.
Like LA County Sheriff Jail. There was a time I think LA County Jail has the most mental health individuals in the whole country.
Mm-hmm. Well, it's the largest hospital.
Thousands of people, thousands.
Yeah, it is the largest hospital in the country. But you're right, it is bombarded. The county hospitals, Arrowhead Regional, LA County, they have a lot of patients, and a lot of times they're just waiting to be assessed and triaged, and it's really sad. I'm sorry, someone else was saying something?
Yeah, I had a question.
Yes.
I work in ER. How do they send out AMA if they're on a hold?
If the patient hasn't been assessed by the doc yet, if they've been assessed by the nurse and not the doc. So let's say the patient comes in and then we do a hold if they come in voluntary on their own and they're waiting to be assessed and they've only been seen by the nurse and not been assessed by the doctor, they can leave AMA that way. If they're on a hold, if they're on an official hold that came in through the emergency department by ambulance, it's a little bit different because then they have been determined by a higher level of care that the patient has is a true 5150. And if that's the case, and it's already been declared, the physician's already seen the patient, then that would be different because that would be an elopement, and then potentially we'd have to hold the patient against their will. We'd have to do an involuntary hold on them.
So,
but it's that interim time between them being triaged and them being seen by a physician, like sitting in the bed or
if they haven't been seen, then you charge us like AMA.
Yeah, you'd have to just say the patient's AMA. Most of the time what we do with that, when the patient goes home, then we'll do like a well check. We'll have the police go and check on the patient at home, and see if the patient's okay at home, if they left AMA, or the hospital will call later and just make sure the patient got home okay. But it's that interim time. It's just, if you've got a patient, unfortunately, that's in respiratory arrest or cardiac arrest, the docs can go take care of that patient first. Sometimes from a triage level, the patient that's complaining of threat to self or threat to others is just that. For right now, it's the threat. It's not imminent. So those patients are sometimes not triaged the fastest. So they're sitting on a gurney waiting for the doc. And especially if they're voluntary, they'll leave, they'll go home. If they're brought in by ambulance, it's a little bit different because they've already been assessed and they're coming in through EMS. It's a little bit different, but it's those ones that are waiting that will leave a lot. Good question, Hunter. Any other questions? Great questions, you guys. Okay, let me finish with this one. Okay, let's go to patients right under the law. They have rights surrounding involuntary commitment and psychiatric advance directives. There's actually advance directives specifically for psychiatric patients as well. Like they can say, especially if they've been off their meds and their psychiatric advance directive says, once I'm admitted to the hospital, please reinstitute my antipsychotic medication. So they can differentiate in a psychiatric advance directive what types of treatment they want as well. Rights regarding restraint and seclusion, most hospitals are trying really hard to stay away from restraints, and that also includes chemical restraints. So giving medications to patients that potentially are going to gork them out or make them super lethargic, or use it as a means of seclusion. And then right to confidentiality. Some, it's a little bit different now with electronic health records, but on an outpatient basis, some mental health records are kept separately from the patient's primary care records, just because of the concern over private health information being leaked. Patient confidentiality obviously is supported by HIPAA. Confidentiality after death is supported as well. Professional communications and confidentiality when it comes to HIV. There are some exceptions to the rule, and that is duty to warn and protect third parties and child and elder abuse statutes. So we're going to talk about that. Okay, what does this mean, duty to warn and protect? So I need everybody on camera for a few seconds so I can talk to you about this. All right, there is a law. The law is called the Tarasoff Law. And the Tarasoff Law is responsible for allowing you as the nurse, me as the practitioner, to call and let a third party know if there is a threat against their life or if there's a threat against that patient. Okay, so let's say you are triaging a patient with mental illness and the patient says, there's this woman that I'm in love with. She's not giving me any attention anymore. When I leave here today, my plan is to take a gun, go to her house and kill her. It is your responsibility as the nurse to not just inform the police, but also to inform that person that has the intention of having something done to them. So let's say that girl that he's going after, it is your responsibility to try and get that information from the patient so that you can warn that person that someone is coming to potentially harm them. Now, I know this is kind of a weird scenario because for all intents and purposes, we want to keep that patient there until we can get the police there to take care of this patient or get the patient into a mental health facility. But if that's not the case and the patient says, hey, I'm out of here, I'm going to get this girl, and he runs away, then it is our duty to try and contact that person to let them know someone has means or intent to hurt them. Now, this came from a direct issue that occurred with a woman named Laura Tarasoff, which is what the law is named after. What it was a psychiatrist was seeing this patient, and the patient said this woman was his object of affection, his object of, he was completely immersed in her, and she did not convey his intentions back to him. And the psychiatrist was talking to him, and he told the psychiatrist that he had planned to go get her, that if he couldn't have her, no one else was going to. He went directly from the psychiatrist's office to this woman's home and killed her in her home. Now, the psychiatrist couldn't keep him there, and upon him leaving, called the police and told the police that this person has this intention, but never called the woman who he was after. And so when it went to court, it was determined that the psychiatrist was held liable because he had seen the patient for more than one time. The patient had said this more than once. It was the doctor's duty to warn way before that this person had this intention. And to do your best to try and elicit from that person, where does this person live? Or even, like having a conversation like, wow, that's scary. Like, where does she live that you would go and do this? And try and get this from the patient so that the doctor could warn this woman that this assailant was coming after her. There's more to this story. There's a lot of different pieces. This thing was in court for a couple of months. And a lot of pieces came out of it, but really what this law determined was that if you feel or are concerned that the health and welfare of someone is in jeopardy, you are legally bound to try and contact that person and let them know that their life may be in danger. So if I had a patient that came to me and say, hey, Dr. M, I'm planning on going and getting a gun and killing this person, it would be my obligation to try and do my best to find out who this person is that they're going after, contact that person and contact the authorities and let them know that this is a concern that I have, because this person has a threat to someone else and has a plan and intention to carry something out. And this happened in, I want to say, the late 70s, and that law still holds to this day. And that's our opportunity. That's where that little creak in the door is, to violate patient confidentiality in order to curtail an event like someone being hurt or something illicit occurring to that person. Does that make sense, you guys? Any questions about that? Go ahead, please.
Do they have to give the name of who's coming after them, or do they have to keep that part confidential?
You can give any kind of information you need to. You have to, because what happens is, like, if the person says, I don't know who you're talking about, who are you talking about? Does this person know me? you have to give them all information about this potential assailant so the person can be warned and can be prepared and know that they need to leave or call somebody else to come in, that XYZ is coming to hurt me, whatever the case may be. Yeah, you have every right to give that information in preparation for safety for the other person.
I do have a question with this. What if the patient like came in and said that they wanted to like hurt or kill themselves, and then after talking to them, they're like, you know what, I'm fine. I'm just gonna go home now. Are you still required to report to the police, or like?
It depends on the extent. It depends on the extent. Like if the person said, you know, they came in and told you that they wanted to take their life, you'd have to dig a little bit deeper. Like there's a bit, like we were saying the other day, when a person says like, ugh, I'm just sick of everything. I just want to be done with it. It's a lot different than I'm just sick of everything. I just want to be done with it. I have a gun. I know where I'm going to do this. I have a plan. I have intention. So you have to look at the whole picture. You know, what we do is we'll do a suicide safety plan. We'll do a risk assessment on that patient, a risk evaluation, sort of categorize how high risk they are for actually doing something like this. And we want to know, do they have a plan and intent? And if they have a plan and intent, then we know that the patient is potentially serious about this. So we have to follow up, and we'd have to do, you know, either escort to a higher level care facility or have an ambulance or a police person transfer the patient to a higher level of care. Plan and intent is your big piece there. Do they have a means? Do they have intention? And do they have a plan?
Right, thank you.
Absolutely. Any other questions? Okay, so that's the Tarasoff law, guys, okay? All right. Okay, so, and again, the other pieces would be child and elder abuse reporting status. That would, you know, we're all mandated reporters. Tort law is a civil wrong for which money damages may be collected by the injured party, the plaintiff, from the responsible party, the defendant. Intentional tort is willful or intentional acts that violate another person's right or property. This law we brought up just because when nurses or providers or physicians are brought into court, they'll use tort law as a reason why. It means that the plaintiff, so the patient, can potentially sue the defendant, which is the nurse or the provider, because they feel that money compensation should be allowed to them because of battery or things done against their will. Intentional tort is willful or intentional acts that violate another person's rights or property. So maybe the wrong that was done with tort was not done intentionally versus intentional tort where the person knew what they were doing. And that includes assault, battery, false imprisonment, invasion of privacy, or defamation of character. Unintentional tort also includes unintended acts against another person that produce injury or harm, and that can include negligence or malpractice. 5 elements to prove negligence are duty, breach of duty, cause and effect, proximate cause, and damages. When we look at ensuring adherence to standards of care, we want to make sure that negligence, irresponsibility, or impairment are all addressed if this is an issue associated with the patient's care, and duty to intervene and duty to report. So it is the standard of care from nurses that work on teams that if a patient, another nurse is doing something that violates these adherences or these ethics or these standards, then you have every right to report that to the charge nurse or to your chief nursing officer. You want to make sure the big piece is, guys, remember, documentation is going to be the big piece. You know, if you're going to give a patient an injection against their will, you have to have substantiation as to why. What was the patient doing? What was the patient saying? How was the patient acting? Were they threatening? Were they threatening to you, to someone else? Were they throwing chairs? Were they, you know, picking up a knife? Whatever the case may be, you want to be able to say, and you should say it. Like, my boss is interesting because, you know, if my patients use dirty words or they say something really, really bad, she'll say, don't say patients used foul language. You have to say patient said, and quote exactly what they said. So if the patient is saying really terrible things, you have to put that in your nursing notes. You have to say patient states, F you, F me, F everybody, if that's what the case may be. And you got to spell it out, which is not always fun, but it gives your gives credence to your documentation. Medical records are used for facility for quality improvement and used as evidence, as well as electronic documentation. Okay, which individual with mental illness may need involuntary hospitalization? This one's for you, Linda. A person with alcoholism who has been sober for 6 months but begins drinking again. An individual with schizophrenia who stops taking prescribed antipsychotic drugs. An individual with bipolar disorder, manic phase, who has not eaten in 4 days.
I would
What do you
say
think, Linda?
C,
Yeah, how come, Linda?
because they have bipolar disorder, and when it's manic phase, that means it's getting worse.
Mhm.
But I would say C, but I'm not sure.
No, you're right. But there's another piece that's the most important piece right there.
Haven't eaten for 4 days.
Yeah, absolutely. Remember that Maslow's hierarchy of needs. Patient still has to have their main needs met too, like eating, drinking, elimination. So we still have to make sure the patient's getting their fundamental needs met as well. So all 3 of those pieces are important, but the big thing that kind of differentiates that is the patient hasn't eaten in 4 days. So we know that there may potentially be other issues associated with a lack of nutrition too. Good guess. Oh, someone repeatedly phones a national TV broadcasting service with news tips. Okay, all right, let's go to the next one. And this one is for, let's see. Let's give this one to, let's see, who hasn't asked to answer a question tonight for me? It's unanswered tonight. Sorry guys, I'm going a little brain dead too. Let's give this one to Alex. Legal and client's rights are suspended when a client is hospitalized involuntarily. True or false? Or not sure?
False.
False, absolutely. Good job, Alex. Okay, client plans to receive to have ECT, electroconvulsive therapy. Which member of the team is responsible for obtaining the client's informed consent? This one's for you, Alyssa. Is it the physician, psychologist, case manager, or the RN?
I'm going to say physician.
Very good. How come?
Well, the nurse could be the witness,
Mm-hmm.
but the physician always has to be the one that gets consent.
Very good. Yeah, I always say that we're the babysitter, so we go to make sure that the signature's there. We don't sign the informed consent or get the informed consent, although it seems like a lot of times we're asked to do it, but it is the physician that needs to do it. We just check to make sure the signature is there. Okay, very good. A nurse was a case manager for a client with serious mental illness for 6 years. The client died by suicide 1 week ago. Today, the client's spouse asked, I always wondered if my spouse was a victim of sexual abuse in childhood. What can you tell me about that? Can the nurse disclose information to the surviving spouse? What do you think, Claudia?
I think no.
No, how come?
Because you're still violating HIPAA even though the patient's deceased, and unless the patient signed a consent and put her that he was, I don't know if it's not really next of kin, but to release information to her, she's not allowed to.
Very good, exactly. If she's not on the advance directive. Very good, excellent, good job.
Would it be okay to say like not sure and play dumb? Or was that looked down upon and you should just be honest saying that you can't?
Yeah, you can't. You can always offer like, unfortunately I can't without proper documentation. You'll need to go through medical records. You can contact medical records to see if you've been placed as, next of kin or in the advance directive. I know it sounds bad, but kind of push it off to the people who are sort of responsible for it anyway, which would be medical records. So they can answer that question. So you don't have to take the onus of it.
Okay.
Good answer. Okay. This is the last thing I want to show you. Look, guys, we're almost out. Okay. All right. This is the last thing I want to talk to you about. And this is the involuntary treatment law. Some of you guys had some questions about it. So let's take a look at it. All right. Involuntary. Oh, let me share this. Sorry, you guys. Okay. So the involuntary treatment law, this is a slide in there for you guys as well. It's under files too. This basically determines danger to self, others, or gravely disabled due to mental health conditions. Okay, so a 5150 is done by police, a medical, it's MCRT is a medically certified something technician, I can't remember, a mental health professional. Medically certified registered therapist, pardon me. They can make the determination as to whether or not the patient will be held on a 5150, which is up to 72 hours, okay? After that, after they're there for up to 72 hours, we can do a couple of different things. They can do hospitalization for up to 14 days if probable cause is found. Again, we need to make sure that there is a court order evaluation potentially, a certificate review hearing. This is automatic within 7 days of detention. Patient is released if probable cause is not found. Post-certification means that they're a danger to others, so they can petition for up to 180 days post-certification. They have the right to court or jury trial for release, up to 18 days hospitalization, additional 180 days if they're still in danger. So the patient can potentially be there for like 6 months. But the big pieces in there is that you'd have to have the court or a jury trial to make that determination. If the hospitalization is for up to 14 days, if probable cause is found, then the person continues to be either gravely disabled. We can petition for conservatorship, like you were talking about early, with like an adult that is found to be incompetent, so they can get a conservatorship via county council. Additional 3 days grace period is allowed. Then you get 30 days of temporary conservatorship hearing, or a jury trial for discontinuation of the conservatorship is done, or conservatorship for a year for a right to hearing anytime regarding placement can be done. I know this sounds really goofy, and it's terrible that I'm using this as an example, but Britney Spears was involuntarily committed to a mental health facility, and then her father became her conservator, and she was very angry about that. And I think it wasn't until recently that her conservatorship was finally released and she's no longer under her father anymore.
Oh, she still is. I'm following that.
Oh my goodness, you're kidding.
She's
huh?
trying to get it. She's trying to get it switched over to like a management group, and she's still fighting it in court.
Wow, interesting. He's still her conservator, huh? Wow, I thought she was able to get it released. Wow, interesting. Thank you. Keep me up to date on that one.
I will.
So you have a right to hearing at any time for discontinuation and every 6 months thereafter. Okay, so here we've got the court-ordered evaluation that anyone may file. This is the right to writ or habeas corpus of hearing. This has to be requested. If it's not requested, the release, if not, they are released if it is not requested, okay? Recertification is when there's danger to self. This occurs the second time at 14 days, and this is the 14-day certification if still suicidal. They have the right to writ for release. This can occur with hospitalization for 14 days, and we must release them unless they remain voluntarily. Okay, now anywhere in here though, you do see that you can have the court intervene, because you know you have your 5150, then you have the 5250, then you have a 5270. So depending on where the patient's at within this spectrum, would allow us to understand the scope of how long they're going to stay there or how long they're going to be kept there. It gives us a good understanding that involuntary treatment law, even though the patient may not want to be there, legally there are steps that the patient has to be allotted. And if they're not, they can potentially leave, because if they're not given their day basically in court or in front of a judge, then we haven't done jurisprudence, we haven't done writ of habeas corpus for them and allowed them to be heard as actual citizens. So they have a lot of rights on their end too. Okay. Any questions? So this one's in there for you guys too, just to kind of take a look at. I have that under files. All right. Okay, guys, I know it was a long night.